It's live, Dr. Sweetha.
Yeah. Good evening, everyone. I'm Dr. Sweetha. I'm a senior consultant in neurocritical care in Artemis Hospital's Gurgaon. So, first of all, I'd like to thank Dr. Punaya and the NCSI team for starting these journal clubs so that we can, be up to date with what is happening in academically as well. So, ICH, I'll be dealing with the Interact 3 trial, which was published just a few days back in the Lancet. So, yeah. So ICH is quite a serious condition, and it is a least treatable form of stroke. And it accounts for about 20% of almost 20 million new strokes occurring globally. And most of the cases are which occurs globally are seen in low income and middle income countries because they have a high prevalence of hypertension and very unhealthy diet, especially with high salt intake in all the cuisines, and other risk factors are also there. So throughout all these years, with all the studies, elevated blood pressure is quite strongly associated with a poor outcome in acute spontaneous ICH patients. So the control of blood pressure becomes a central component in the management of acute ICH patients. But all these randomized controlled trials which have been done so far, there are quite regular inconsistencies in their results. We have a lot of studies, especially focusing on blood pressure control, like Interact to Attach to ICH Adapt trials. But there is little evidence in patients, especially who have a large intracerebral hemorrhage or who require neurosurgical intervention. So these limitations have kind of restricted the uptake of this strategy in clinical practice. So, and there is an absence of a proven medical or a surgical treatment for the treatment of intracerebral hemorrhage. So, there is basically a lower threshold for withdrawal of active care in such patients, which is quite a sharp contrast to the modern systems of care which happens in patients with acute ischemic stroke. So, over the last few years, interventions in terms of multimodal approach has been tried. And one of the studies, which was an Australian cluster trial, which was published in 2011, which focused on managing fever, hyperglycemia, and dysphagia in acute stroke patients. They took both hemorrhagic and ischemic stroke patients. They found that the patient's functional outcomes were improved with this sort of a multi-intervention protocol. This particular study was supported by a UK study in 2019, which included the reversal of anticoagulation, intensive blood pressure lowering, and rapid triage in neurosurgery and critical care. And that study also lowered 30-day case fatality after ICH. If you look at the post hoc analysis of the second phase of Interact 2, which basically looked at the higher scores which were associated with elevation of systolic blood pressure, blood glucose, body temperature, and previous use of anticoagulants, which all independently predicted the poor outcome after ICH. So, all these studies formed the base of coming up with a intensive care bundle for the blood pressure reduction in acute cerebral hemorrhage trial. That is the Interact 3 trial. This was published on May 25th, 2023 at the Lancet, and this included a lot of it included the interactive investigators, and basically they aimed at establishing whether implementing a goal directed care bundle protocol for early intensive blood pressure lowering and management algorithms for hyperglycemia, pyrexia, and abnormal anticoagulation, which were implemented in a hospital setting, whether it could improve outcome of patients with acute spontaneous intracerebral hemorrhage. So this was an international, multi-center, prospective, blinded endpoint, stepped wedge cluster randomized controlled trial. And this trial was done across 9 low and middle income countries like Brazil, China, India, Mexico, Nigeria, Pakistan, Sri Lanka, Vietnam, and one high income country, which is Chile. There was only one center from India, which was a Christian Medical College and Hospital, Ludhiana. All the other centers were from abroad. So, in this particular study, what they did was they randomly allocated hospitals to all across these countries, and they were allocated to switch from usual care to intervention at different time points. And these cluster of patients which were in these sites were prospectively followed up to establish their functional outcomes. This particular study design, this new approach was basically done to mirror usual change in the clinical intervention protocol in any hospital. So, this study followed the consolidated standards of reporting trials extension reporting guideline available for stepped wedge cluster randomized control trial. So, the ethics committee approval was done by the respective committees in each hospital, and they implemented a mixed consent process, as in, there was a cluster guardian to provide consent for patients to receive intervention as part of the routine care, like a senior delegate was allocated to give the consent, or even the chief executive officer of that particular hospital could give the consent, and the patients or the participants or an approved surrogate of the participant was they basically gave the written informed consent for collection of social demographic medical and clinical information, and they gave the consent for a follow-up call at 6 months to figure out the functional outcome of these patients. So the eligible sites were allocated. Basically, they were approached through neurosurgery and neurology professional networks. And to be eligible, these hospitals basically either had no or inconsistent protocols for managing the abnormal physiological variables, which you can see in patients with acute ICH. And they were willing, those who were willing to implement the interventional care bundle protocol as part of the routine care, because it required for them to change their usual clinical practice. And these hospitals should have had a local representative who was termed the champion, who was willing to lead this particular study in the hospital and to be able to provide the required study data. So the inclusion criteria were consecutive adult patients aged 18 years or above who present to the hospital within 6 hours of onset of the signs of acute ICH, and all of them had to be image proven. The exclusion criteria was ICH secondary to structural abnormality in the brain like AVM, aneurysm, tumor, trauma, secondary to reperfusion, bleed secondary to reperfusion therapy like thrombolysis, thrombectomy, and if the treating clinician judged that the participant was unlikely to adhere to the study treatment or follow-up regimen, so then those patients were also excluded. So basically, what is all the hospital sites were called clusters. Okay, all of them were basically divided into three sequences of 4 periods each, as you can see, right? So what happened was these 4 periods, basically for period one, all of them were doing the usual care as suggested by the pink box, and the care bundle, which is the intervention protocol, is suggested by the blue boxes. So the hospitals allocated to sequence one started changing their intervention, that they started going into the intervention from period 2 onwards, and sequence 2 hospitals started going into the intervention protocol from period 3, and sequence 3 hospitals changed it from period 4 onwards. So this is what is a stepped wedge trial is all about. So then, to avoid contamination, basically the details of the intervention, the sequence, the periods with which in which they are in were all concealed from the sites until they had completed the usual care control periods. And between the change over into the usual care to a care bundle protocol, 7 to 10 days time were allowed for the sites to get their key staff to be trained in the transition and even in the study data, the protocols. So and their key staff was trained, masked, and they were trained to do undertake telephonic assessments of the outcome of patients at 6 months post randomization. So this was how the study was designed, and the care bundle included. This is the 4 points of the care bundle, and it included early intensive blood pressure management. That is a target blood pressure, systolic blood pressure of less than 140 nm Hg within 1 hour of initiation, and the cessation of treatment for the intensive blood pressure management was when the systolic blood pressure was 130. And intensive blood sugar control in patients without diabetes was 6.1 to 7.8 millimoles per liter, which amounts to 110 to 140 milligram per deciliter. And the patients with diabetes was the target blood glucose levels which were required to be achieved was 7.8 to 10 millimoles per liter, or which amounts to 140 to 180 milligram per deciliter. And this could be achieved as soon as possible once the intensive treatment was started. Treatment of pyrexia, for that, the target was less than achieving the temperature of less than 37.5 degrees Celsius within 1 hour of initiation of the treatment, and reversal of abnormal anticoagulation, especially in those taking warfarin, was the goal was to keep the INR less than 1.5 within 1 hour of initiation of the treatment, and that could be done with either PCC or FFP. And all these target concentrations within the care bundle were to be maintained in patients for at least 7 days or until discharge or death of the patient, whichever came earlier. And all these sites were required to record all their data on a daily basis, and there were monthly performance reports of the site, so that any intervention or anything which needs to be implemented or any training, extra training which needs to be done, could be done at a regular basis. And there were mandatory online quality improvement meetings to be attended by the site staffs. At least two they had to attend every month, so that was also happening regularly. And for continuity of the recruitment of all the patients, basically what they did was they required all these sites to recruit all the patients with diagnosis of ICH into the screening and enrollment database, irrespective of the time of onset of the symptoms. So the follow-up data, basically on clinical status, the management and outcomes, were taken at day 1, day 7, and at 6 months by telephonic assessment. And brain imaging was done at presentation and 24 hours and day 7 of the treatment. And they are currently working on the results of a centrally educated brain imaging. They will be presenting it in future publications. So the outcomes were: primary outcome was functional recovery at 6 months, which was measured by the MRS score, modified Rankin score scale, which was ranging from 0 to 6. And we all know that 0 to 1 indicates a favorable outcome without or with symptoms of, but no disability. And scores of 2 to 5 indicates an increasing amount of disability, and score 6 indicates death. The secondary outcomes basically included the dichotomous analysis of the MRS scores at 6 months, basically with the disability or death, that is 3 to 6 versus 0 to 2, and 3 to 5 MRS score versus 0 to 2 in survivors. And death at 6 months neurological deterioration at day 7 as per the NIHS score, and health related quality of life, which was defined by the Eurocall 5 dimension questionnaire, and the residence of these participants at 6 months, be it home or other. So the time of discharge was also recorded, and recorded at day 7 to coincide with the other parameters which we were checking. The statistical analysis, this study was designed with a power of 90% to detect common odds ratio of 0.8 for worse functional outcomes at 6 months using ordinal logistic regression. And the required sample size was measured by PASS software 2019, and it calculated that they required an average of 19 patients recruited per phase at each participating hospital. That is around 110 sites with 4 phases and 19, which amounted to 8,360 patients. And the significance threshold for primary outcome was p-value less than 0.05. So, with all these, they initially approached 206 hospital sites were assessed for eligibility, out of which 62 sites were excluded because they couldn't gain approval. Few centers had very few eligible patients, and some were not interested at all. So out of the after deducting all that, 22 sites dropped out even before any patients were recruited. And out of the 122 clusters analyzed, like I showed you earlier, they were divided into 3 sequences with four periods each. And so basically, ultimately 121 clusters were analyzed, and because they did a continuous recruitment, they screened around 10,857 patients, out of which 3,821 patients were excluded, of which most of them had come after 6 hours of the onset of ICH. So then out of this 7,036 patients were ultimately randomly assigned. 3,021 were allocated to the care bundle, which was the intervention protocol bundle, and 3,815 were allocated to the usual care bundle. What happened was they started collecting the data from 2017, but by 2019 and 2020, everyone, the pandemic hit, so a lot of recruitment was completely stopped in many of the hospitals, especially in the Asian hospitals. So they had to do amendments to their initial study design. So initially the periods, each period were for like 3 months. But in most of the Asian countries, they had to extend the in the periods to 4 months, because the COVID pandemic hit when most of the hospitals which were recruited into the study were in the the intervention care protocol. So that was one thing that they had to do. So to allow more hospitals to participate and to allow more patient allocation as well. So if you see in the results, the demographic data, everything mostly is comparable. The BMI was also more or less the same, 24. The medical history was quite comparable, like history of hypertension, previous ICH, heart disease, and everything. That was all comparable across the groups. And if you see the NIHS score, that was 13 in both the groups, and the GCS also, the score was in the median was 12 across the groups. The volume of hematoma, if you see, it is also comparable. It was 15. The median ratio was 15 between both the control group and the intervention group. And mostly out of all the hematomas, if you see the location of the hematoma, the most of the hematomas were quite deep, amounting to nearly 81 to 82% of all the hematomas evaluated. The all the patients, the MRS score before the onset, most of the patients belong to score 0, and most of them were on antihypertensive medications. And on presentation, the mean systolic blood pressure, which was seen in both the intensive care bundle and the usual care bundle group, was coming to 174 of Hg. So the presumed cause out of all these spontaneous ICH cases, mostly it was presumed to be because of hypertensive vasculopathy, because 95 to 93% of patients were with hypertensive vasculopathy. And the abnormal physiological variables, particularly for this study, was mainly systolic blood pressure. I already told you most of them had hypertension. And the blood glucose levels, around 34.5% of patients in the intensive care bundle and 37 patients in the usual care bundle had high blood glucose levels. But if you see the body temperature, the pyrexia and INR were abnormal in very, very less percentage of patients. So if you see the treatment in the first 24 hours, the proportion of patients who were administered intravenous blood pressure lowering agents was quite high in the care bundle group. That is the 78.9% in the intensive care bundle group, and the usual care bundle group was 70.9. And the median time, because if you remember the care bundle, the time to reach the target systolic blood pressure of less than 140 was they had to achieve it within 1 hour. So because of that intensive blood pressure lowering, the median time to reach the target in the intensive care bundle was 2.3 hours as compared to 4 hours in the usual care bundle group. And the most of the antihypertensives which were used was basically urapidol was used in around 3,351 patients, which was amounting to 61.2% of patients, which is actually an alpha 1 antagonist and a combination of serotonin agonist. So that and labetalol was used only in 12.1% of patients. So these were the usual antihypertensive medications which they found that the hospitals were using. The other antihypertensive medications were SNP, nicardipine, and nimodipine were also used. The blood glucose targets were mostly achieved. They 13.4% of patients they managed to achieve it within 1 hour, and if you see the median time to reach the target was same in both the groups. The hyperpyrexia also, patients had more frequent control of their body temperature in the intensive care control group, that is the 86.5%, compared to the usual care group. And the time to reach the target was around 3 hours compared to the 4 hours. And INR also was more faster achieved in the intensive care bundle group. So, but if you overall, if you adjust the mean differences over 24 hours between the two groups, especially for hyperpyrexia and abnormal coagulation, there were no clear differences. So the main difference was mainly for intensive blood pressure lowering treatment group. And if you see the other management modalities from day 2 to day 7, the other management modalities like decompressive surgery, mechanical ventilation, intensive care admission, and even assisted feeding were quite comparable between both the groups. If you see the functional outcome at 90 days in the care bundle and the usual care groups, definitely the care bundle, that is the intervention group, had much better low scores on the MRS levels. The lower MRS scores were much better for these patients in the intervention group, and the common odds ratio was around 0.86 for an average effect across all MRS across all the groups. And the secondary outcome results were also quite consistent with all the point estimates basically favoring the intensive care bundle group, including there were significant differences seen in mortality at 6 months, the health related quality of life, like the mean overall health utility score was quite significant in the intensive care bundle group, and the hospital discharge also was quite significant. Compared with the usual care group, the care bundle had lower odds of death over 6 months in the primary model. But there was no significant difference in the odds of death or disability at 90 days, and even for death or neurological impairment measured by NIHSS at day 7 of the treatment. So, the use of this, the final, this thing is that the use of this care bundle protocol, it resulted in improved functional outcome definitely at 6 months as measured by the modified Rankin scale, and basically an implementation of a time sensitive care bundle helped them in improving the survival, the quality of life, and definitely the intensive care bundle group had less serious adverse events. And this is the first phase 3 multi-center randomized trial to show a positive outcome for an acute treatment of ICH. So, this particular study had quite a few strengths, but the main ones, what I want to highlight is the evaluation of they evaluated a complex intervention basically for implementation in real world settings, and they assessed the clinical effects on patient centered outcome at 6 months. And there was a large sample size, so clinically it was a clinically worthwhile benefit they could show. And because it was spread across low middle income countries and high income country as well, Chile was one high income country which was included, and across different cultural and different socio demographic data, basically this whole protocol can be basically generalizable, and we can implement it all over the world. That was one of the major strengths which I found in this particular study. The limitations, basically it was quite challenging to obtain early consent in severely ill patients, especially, and who underwent urgent neurosurgery. Then all the hospitals had to get tuned to a new change in their clinical practice across different services, not just the medical personnel, other services as well who were involved in the patient care in multiple centers across the world. So there was a potential for contamination of the data, selected bias, then considerable heterogeneity in recruitment of patients across sites, and there was considerable heterogeneity in the timing phases of the trials, especially because the COVID pandemic hit. So there was a lot of issues regarding the number of cases and the number of hospitals which were finding it quite difficult to recruit patients at that time. Their study was not powered to detect differences across the secondary outcomes, but basically all the secondary outcome, the direction of their effect was pointing to consistently in favor of the care bundle group. And they found difficulty in monitoring data quality in low income countries, and they found it difficult to logistically found it difficult to follow up the patients by telephonic assessment. And telephonic assessment means probably the person who is attending to the call might not know exactly what does the staff want to know about the exact clinical improvement. It is very difficult for a non-medical person to figure out and tell the researcher. So all this evidence basically support the adoption of an active protocol and a time sensitive protocol for intensive blood pressure lowering and associated management of key abnormal physiological variables within several hours after the onset of signs to improve the recovery of patients with acute ICH. So this this set of investigators have asked all the hospitals to implement this particular interventional approach to help in improving the functional outcomes of patients with acute spontaneous ICH. Thank you. I'll stop. Should I stop sharing the screen? Is
I think we are able to view the presentation
yeah.
here. Yeah. So I'll just go ahead. Okay. Good evening, one and all. First of all, I'd like to thank NCSI for this kind opportunity. I have been an ardent follower of the classroom series since my student days in DM Neuroanesthesia, and it is indeed a privilege to be a part of this session today. Today, I'll be talking on this very interesting study, that is the brain bend study. As we all know that as the evidence-based practices have evolved, the use of lung protective ventilation, which utilizes more physiological tidal volume with appropriate levels of PEEP, have been employed for our group of patients in ICU, not only in ICU but also in perioperative settings, to decrease the pulmonary complications as well as improve outcomes. So, but even today, we are still reluctant to use lung protective ventilation when it comes to acute brain injury patients, and even the latest European Society guidelines have not very strongly suggested the use of lung protective ventilation when it comes to acute brain injury. So this study will provide us important insights on why and how we should monitor the brain while using this intervention of lung protective ventilation in acute brain injury patients, and if at all, if it can be employed for our group of patients, that is acute brain injury patients. For doing the same, my senior resident in DM Neuroanesthesia, that is Dr. Bhargavi Vallavi Nene, will be presenting and taking us through the study. And after her talk, there will be a 5 to 10 minutes discussion on the same. Over to you, Bhargavi.
Hello, am I audible, ma'am?
Yes, you're audible. Please go ahead.
Is my presentation visible, ma'am?
Yes, it is visible.
Okay. Good evening, everyone. I'm Dr. Bhargavi from Department of Neuroanesthesia from Christian Medical College, Vellore. I'll be discussing on this journal club discussion, Brain Bend Study. This session will be moderated by Dr. Keta Thakkar. Madam is an associate professor from Department of Neuroanesthesia, CMC Vellore. Brain Bend Study. Brain study by et al. Published in CMC Critical Care from Springer Nature in March 2023. This was titled as Neurological and Respiratory Effects of Lung Protective Ventilation in Acute Brain Injury in patients without lung injury. This is a single center randomized intervention study. A brief introduction about ventilative strategies. We don't have a clear consensus on whether to use lung protective ventilation in acute brain injury patients or not. ICU physicians are still hesitant, and there are reservations of using lung protective ventilation in view of perceived rise in ICP fear and hypercapnia and associated changes in cerebral autoregulation. There is still conflicting evidence regarding use of low tidal volume and PEEP in our acute brain injury patients. There is new evidence and strong recommendation on ventilation strategy recommendations for ABI is the need of the hour. ICP alone may not reflect the underlying perfusion and intracranial compliance. Hence, ICP monitoring along with cerebrovascular reactivity, that is the pressure reactivity index and the compensatory reserve index, were used in this study. Lung protective ventilation along with transpulmonary pressure and mechanical power were also mentioned in this. Iterate the PEEP according to the primal components. Lung protective ventilation, they have these the authors have hypothesized that lung protective ventilation would not induce significant changes in neuromonitoring derived variables, provided that the baseline ICP was less than 22 millimeters of mercury. The aim of the study was to investigate the effects of lung protective ventilation on brain pathophysiology, as determined simultaneous monitoring of transpulmonary brain oxygenation and also indices derived from the ICP waveform analysis. This was a single center randomized interventional crossover study. It was conducted in a tertiary trauma and neurosurgery center. This trial was registered with Regional Committee for Medical Research in Northern Norway. This study was conducted over a period of 2 years from May to 2000 criteria. All acute brain injury patients were screened at ICU admission, and all the acute brain injury patients who required controlled ventilation and ICP monitoring were included in the study. Acute hemorrhage, subarachnoid hemorrhage, and traumatic. Patients who had baseline ICP of more than 22 millimeters of mercury and preceding decompressive craniectomy history, presence of open and external ventricular drainage, acute history of patients in acute hypoxemic respiratory failure defined by PF ratio of less than 300 millimeters of mercury, and presence of chest infiltrates, and any history of severe lung disease. Obese patients with BMI of more than 35 kilogram per meter square and known cardiac failure patients were excluded from this study. This was a crossover type of study where patients were divided into 2 groups and interventions were randomly allocated to each group. During period 1, the group A was allocated low tidal volume and low PEEP. The low tidal volume was defined as 6 ml per kg of predicted body weight and low PEEP, that is 5 centimeters of water. Whereas group B was allocated with the intervention low tidal volume, that is again 6 ml per kg tidal volume of predicted body weight, and high PEEP, that is 12 centimeters of water. This ventilation settings were continued for 2 hours, after which all the patients in each group were given a washout period of 1.5 hours, where they were ventilated with their baseline ventilatory settings, keeping in mind the PaCO2 values. And the baseline ventilatory settings included 9 ml per kg tidal volume of predicted body weight. After the washout period, again during period 2, the group A was crossed over to the other intervention, that is low tidal volume and high PEEP, and the group B was given low tidal volume and low PEEP for the 2 hours. This study followed the CONSORT guidelines, and this is the allocation and randomization of the patients in the study. 58 patients were assessed for eligibility, out of which 28 were excluded, 25 because they had not met the inclusion criteria, 1 declined to participate, and for other 2 because of other reasons. 30 patients were randomized and randomly allocated to each groups. Group A had 14 patients, Group B had 16 patients. During period 1, as already stated, Group A received the intervention of low tidal volume and low PEEP. All the 14 patients allocated to this group received the intervention, and there were no interruptions. Interruption was defined as breaching of safety limit of ICP more than 22 milligrams of mercury for more than 5 minutes. If the ICP reached more than this value, the cases were the intervention was interrupted and not continued. During period 1 of group B, 16 patients during period 1 of group B, they received the low tidal volume and high PEEP intervention. All the patients allocated to this group received the intervention. Although 3 people had to be interrupted due to breach of safety limit. Again, after a washout period of 1.5 hours, during period 2, the group A received the intervention of low tidal volume and high PEEP, and 1 patient did not receive the allocated intervention due to hemodynamic instability due to pneumothorax, and 2 patients had to be interrupted due to breach of safety limit. In the group B, during period 2, all the patients allocated received the intervention, but 3 had to be interrupted due to breach of safety limit. Coming to the analysis part, all the patients in the group B, 16 patients, were analyzed, but in group A, 3 patients data was excluded due to pure qualitative by a program, Red Cap, and the worker who monitored the safety endpoint was blinded to the intervention arm. The minute ventilation in between the interventions was in between and during the interventions was maintained close to the baseline so that so as to minimize the CO2. If required, by inclusion into the study. Outcome measures. The primary outcome they looked at was effect of lung protective ventilation on ICP and pressure reactivity index. The endpoints of this primary outcome was percentage of patients who could successfully complete the protocol without interruption, that is, not reaching the safety limit of 22 millimeters of mercury of ICP, and non-inferiority of mean ICP, which they have defined as increase in ICP more than or equal to 3 millimeters of mercury, which they have considered significant, and non-worsening of pressure reactivity index from baseline to intervention. The secondary outcomes they looked at was effect of lung protective ventilation on compensated reserve index, that is RRP, and brain oxygen as monitored by NIRS. Local ICU protocol and for sedation and hemodynamic to maintain the sedation and hemodynamic targets. All the patients were deeply sedated with a RAS score of achieving a RAS score of -5 using IV infusions of propofol and fentanyl and midazolam if needed. None of the patients were paralyzed with neuromuscular blockers. All patients were given a head and elevation of 20 degrees and targets of cerebral perfusion pressure of more than 60 mm Hg, PaCO2 between 34 to 36 mm of Hg or 4.3 to 5 kilopascals was kept as a target, and PaO2 target of more than 10 kilopascals and a saturation target of more than 96% and plateau pressure maintained less than 30 centimeters of water. Hemodynamic and other targets were achieved by fluid resuscitation or vasopressor as per the treating clinician discretion. Coming to the ventilatory strategies, all the patients were ventilated via volume control ventilation with IE ratio of 1:2 and inspiratory time of 10%. And minute ventilation was according to the PaCO2 target that was set. Same with FiO2. In between interventions, the minute ventilation was brought back to baseline. The ABG analysis was done after 30 minutes of change of each ventilatory settings. Intervention was interrupted when ICP crossed the safety limit of more than 22 mm of Hg for more than 5 minutes. These were the parameters and data collected. This is the ventilatory parameters they looked at was airway pressures, flow, esophageal manometer was placed to record the pleural and respiratory mechanics analyzed respiratory and expiratory holds, and PEEP was measured. The neurological parameters were measured with the ICM software. The parameters measured were the ICP, the arterial blood pressure, the NIRS, entitled carbon dioxide, and PEEP. And based on the ICM software, the derived parameters were pressure reactivity index and the compensated reserve index. And based on the intrapleural pressure, the transpulmonary pressure was calculated. All this were collected by electronic data capture and the severity of brain injury and type of the brain injury was also recorded. The ICP sensors used were intraparenchymal and both ventricular also were used. This is a screenshot that the authors have provided of the ICM software that they have used during each intervention. This is during baseline intervention, baseline ventilation of the patient, and low tidal volume, low PEEP intervention, and coming back to baseline during washout period again, and the high PEEP, low tidal volume and high PEEP intervention. Similarly, these are the ventilatory mechanics that were being monitored. The sample size was calculated based on the primary outcome of ICP and crossover design, and sample size that was arrived at was 28, but including the dropouts, they decided to take a sample size of 30. The treatment effect was compared between baseline and intervention with a paired t-test and Wilcoxon sign rank test based on the type of variables and distribution of the data. Changes induced in hemodynamic variables due to intervention were plotted as scatter plots and Pearson correlations. Coming to the results, tight control of EtCO2 and PaCO2 was maintained in this group to prevent the confounding effect of carbon dioxide on the ICP. So if you look at the baseline characteristics in all the patients that 27 patients that were analyzed, the PaCO2 was similar in all the patients. Mean PaCO2 was 35, and the PF ratio was 343. They had excluded all patients with acute hypoxemic failure, and the transpulmonary end expiratory pressure had varied between minus 0.553 to 4.5, which will be discussed later. Other baseline characteristics, 59% of the population was male, and the mean age of the population was 54. And coming to the type of injury, 44% of the patients had intracerebral hemorrhage, and 41 patients had a traumatic brain injury, but only 15% of the patients had subarachnoid hemorrhage in this. And most of the patients had a GCS of less than 8, which required ventilation, hence being included in the study. Coming to the primary outcomes, the authors found that there was no clinically significant rise in ICP in both low and high PEEP. They had found a difference of ICP of 2 and 2.2 and 2.3 between two interventions of low and high PEEP, which was not, even though it was statistically significant, it was considered clinically irrelevant. If you look at these graphs that they have given, this is the y-axis shows the mean ICP, and this and the group, the intervention group on the x-axis. At baseline, the black lines represent the patients who had successfully completed the study, and the red lines represent the patient who had to be interrupted, which were overall 6 patients. So if the patients who had to be interrupted from the study, if you see, had a higher baseline ICP as compared to same with both interventions, low PEEP and the high PEEP intervention. Coming to the pressure reactivity index, if you see at again comparing with both interventions, low PEEP and high PEEP, it was not very significant between two interventions. Also not very significant between the completed group and the interrupted group. Also, 6 patients had to be interrupted from the study due to breach of safety limit of ICP. The other outcome variables, if you see the ICP, as I've said already, even though there was slight rise of ICP from baseline to intervention, even with low PEEP and high PEEP, it was considered clinically not relevant. And if you compare between low PEEP and high PEEP, and the difference is not statistically significant. Same with pressure reactivity index. Between high and low PEEP interventions, there was not much change of pressure reactivity index, indicating that cerebral autoregulation was maintained. To reserve index into the baseline in low considered, and between the two groups it was not significantly elevated, indicating that brain compliance had not worsened due to the intervention. Similarly, regional oxygen saturation of the brain was not significantly different from between two interventions. The secondary outcomes that they had looked at was compensatory reserve index and regional saturation, which I've already described, and also the effect on gas exchange. They had observed increase of PaCO2 from baseline by around 2, but it was not clinically relevant. And effect of and the respiratory mechanics of between high PEEP and low PEEP was found to be not clinically relevant, and mechanical power, even though was maximum in high PEEP intervention, it did not exceed the safety limit, and it was anyway anticipated due to the presence of high PEEP. If this graph compares the baseline characteristics of the patients who were successfully able to complete the study, as well as patients who had to be interrupted from the study. These are violin and box plots, and the y-axis shows the ICP during the baseline and the intervention outcome on the x-axis. This baseline had more evenly distributed ICP, lower than the 20 mmHg, and interrupted patients had higher baseline ICP. Similarly, if you compare the RAP between the completed and the interrupted group, the RAP tended to be higher in the interrupted group, indicating they had lower brain compliance to begin with. So this study I found was a good study in which it was the first clinical study attempting to elucidate the effects of lung protective ventilation on brain physiology in acute brain injury patients without lung injury, and it was simultaneously assessed by simultaneous monitoring of respiratory mechanics and also neurophysiological variables. The main takeaway point of this study was that most of the patients with acute brain injury had no adverse effects of lung protective ventilation, neither on the ICP nor on the cerebral autoregulation, and this was independent of the PEEP levels applied in the study. Although nearly 1/4 of the patients, that is 6 patients, had a transient rise in ICP and had to be interrupted. The high PEEP strategy was, as expected, associated with high index transpulmonary pressure and mechanical power. All patients except one during the study were hemodynamically stable and adequately volume resuscitated. There was a tendency spider between PaCO2 in the interrupted population. The mechanical power also was highest in the interrupted population, indicating they might have a lower compliance of the lung as well. No, there was no relationship between transpulmonary pressure and interrupted events, and no significant correlation with respiratory compliance between the two interruptions. And when the high compliance of the respiratory system. There is a lot of reviews of talk and on brain lung interaction. Already know that acute brain injury itself a predisposing factor to acute lung injury. Other than neurogenic pulmonary edema and ventilatory associated pneumonia, the acute brain injury itself causes neuroinflammation, autonomic dysfunction, and these patients, even though initially at baseline don't have a lung injury, can develop later. So there is always a question whether to initiate lung protective ventilation in these prophylactically. This review article by Zyka has acknowledged that lung protective ventilation should be considered in acute brain injury patients, but it has not strongly recommended, and it has recommended for further studies to be done. Similarly, even in ARDS patients, because of the brain-lung crosstalk, there will be primary hypoxic injury, and there are increased chance of stroke in ARDS patients. Again, the question of whether these patients need to be monitored for ICP also is a question. So again, this is a knife edge walk where you have to balance both the brain and the lung. So again, this is a study by Taran et al., which they have recently published in 23, in which they have acknowledged that lung protective ventilation does seem to be safe in patients with acute brain injury, but they have asked. But they said that this data it has been extrapolated from ARDS patient, and the need for studies in acute brain injury patients is required. Again, there are 2-3 studies that have been done in intraoperative period also. This is a study by Jiang et al., which looked at effect of intraoperative lung protective ventilation on clinical outcomes. They had all looked at postoperative pulmonary outcomes as well as neurological outcomes. They had compared baseline ventilation with high PEEP and recruitment maneuvers, and they have stated that postoperative pulmonary complications were less in patients with lung protective ventilation, and neurological outcomes were similar. But this was an intraoperative study, and small sample size was included. Again, there are some of these studies have again, they have all remained inconclusive, and one study has stated, based on the CT, that trauma, first 24 hours trauma, the lung is more recruitable, and the lung protective ventilation may not be required during the first 24 hours, which is still debatable. Again, coming to the European consensus, this was consensus sort of a guidelines they had tried by European Society of Intensive Care, by all the treating ICU critical care physician, and there was no strong evidence for any of the recommendations. Only recommendations with very low evidence was that lung protective ventilation was in favor of lung protective ventilation in patients who do really require it. The limitation of this study was it was a single center study with a small sample size, and the power analysis of the study was based on retrospective ICP data, and the authors themselves acknowledge that change in ICP should have been monitored with slow and gradual increase in PEEP rather than an abrupt change in PEEP from low to high. And the cardiac output monitoring and brain tissue oxygenation measurements were not done during the study. So to conclude, lung protective ventilation seems to be a safe and feasible option in ABI patients, but careful selection of patients is required, and caution in patients with decreased brain compliance. And even if it is being administered, it should be done so with neurological and ICP and proper monitoring. Thank you.
Thanks, Bhargavi, for the presentation. We'll have a short 5 minutes discussion on this study. This group of study, their inclusion criteria was acute brain injury patients who are intubated and on controlled ventilation in the ICU were included with ICP not exceeding more than 22 millimeters of mercury. And they did not include patients who had acute hypoxemic respiratory failure. Can you give a reason why did they particularly exclude those group of patients?
I feel they had excluded these patients because they were trying to keep a tight control on the PaC2 values and the baseline PaC2 values, because they wanted to eliminate the confounding effect of the CO2 on the ICP as such. And they just wanted to look at the intervention. But and in ARDS, their targets are little variable, both the permissive hypercapnia and saturation targets. I thought maybe that's why they have decided to exclude. And most of the patients, most of the studies have excluded the ARDS patients, and ARDS studies have excluded the acute brain injury patients. So more studies are required.
Yeah. true. And there was this retrospective study in which the lung injury patients from mild to severe were included, and they saw that in these group with acute brain injury were included, and they saw that in this group of patients there was an effect in the form of CP. Hello, Bhargavi.
Sorry, ma'am, you're not clearly audible. Can you repeat the question?
No, I'm just explaining that how the retrospective study had shown that the patients who had an acute lung injury with acute brain injury were monitored, and they showed that there was an increase not only in ICP but also decrease in cerebral perfusion pressure whenever the patients had a severe lung injury in the form of very low PF ratio. So they did not want to have this problem in this group of patients, so they have specifically excluded, and they have used this retrospective study as a reference study not only for their clinical parameters but also for their sample size calculation. So there is this very interesting study design of crossover study, and any idea on what it is and what is the significance of that?
So this crossover study, ma'am, is actually in the same set of group of patients. There are two interventions corrected, interventions carried out. So that way, the random specific characteristics of the patients are excluded, and the power of the study is more, and the results are more significant.
And there are certain limitations also to it. That is, there can be a problem of carryover effect because both the interventions are included in the same group of patients. So in this study as well, there was this problem of carryover effect of the ventilation parameters, and it was especially observed when it came to driving pressure. So they have asked to not take into consideration the driving pressures when it comes to seeing the intervention effect on the lung compliance. But they have mentioned that in the results section, and they have shown it the mean and standard deviation values of the driving pressure as well. So there can be this problem of carryover effect when it comes to a crossover study design. So
Yes,
there were certain parameters that were used for respiratory compliance. Can you explain them? What were the different parameters that were used?
Yes, ma'am. So both along with monitoring the PEEP and the plateau pressures with inspiratory and expiratory hold, they had monitored pulmonary pressure. The pressure across lung is between the intrapleural is a manometer, the pleural pressure, and pressure was taken as a surrogate for the alveolar pressure. So the difference is they have considered as a transpulmonary pressure. So now this is coming up in a new way, ma'am, because especially in obese patients where their chest compliance where chest compliance is low, and then that contributes to a lot of resistance. That which third was indicated the
Your voice is breaking. Your voice is breaking in between.
No?
Network error from your side. There is some network error from your side, probably.
Okay.
Maybe you can stop blurring the background. Maybe it'll get better. Something like that. It uses more.
Okay.
Okay, so we were just talking about mechanical power and the transpulmonary pressure. Mechanical power is a new parameter to see the respiratory compliance, and it is especially used for patients who are having ARDS, mainly to see the effect of mechanical ventilation, which is a cornerstone for ARDS patient, to see the effect of it and its effect on the ventilator-induced lung injury. So they have it's a bedside calculation of all the different parameters of respiratory rate, mechanical ventilation, and inspiratory flow. So we are not routinely using it in our institute. And transpulmonary pressure is again a new way to see the respiratory compliance, which has been used and explained by Bhargavi. Can respiratory compliance have an effect of how the protective ventilation can affect the ICP in acute brain injury?
Yes, ma'am. So there was a study by Masika et al. Which had seen, and they have stated that as long as the alveoli were recruitable, the PEEP was okay. Once the PEEP was causing over distension, that is decrease in compliance of the respiratory system, that was deleterious to the brain as well. So that also caused rise in ICP and decrease in perfusion pressures.
So we noticed that the group of patients that were included were traumatic brain injury patients, subarachnoid patients, and ICH patients, out of which SAH patients were considerably low. Only 14% of patients comprised of SAH patients. Any idea? I mean, have they written
Yes,
why?
ma'am. They have mentioned that, acknowledged that most of the SAH patients they try to recruit had an open external ventricular drainage, which they have proposed as an exclusion criteria. So they had selectively excluded such patients, and most of them turned out to be patients with SAH. So only I think 4% they have included are SAH.
Apart from that, apart from the limitations that they have already stated, can you think of certain limitations of the study?
The limitations that I thought of was, ma'am, that they had not looked at long-term outcomes of any of these interventions, neither the pulmonary outcomes in the long term or the neurological outcomes in the long term. So that was one thing, and there was. They had in their supplementary section, they had mentioned that they had excluded some data due to opening of the EVD, which improved the compliance of the brain, and the indication for opening the EVD was raised ICP. So this was done in some 16 patients. So they have not clearly explained about this. So that one I thought may have caused some confounding effect.
Sure. All right. Yeah. So when it comes to our institute, we do institute lung protective ventilation when it comes to acute brain injury patients with a careful titration of the PEEP, especially in patients who already have an ICP monitoring device in situ. We look at that and then we monitor it accordingly. And apart from the brain vent study, which is now followed by a big international multi-centric venti brain study, which is again a prospective observational study to see the global pattern of how mechanical ventilatory parameters can affect the acute brain injury patients, is being is now being instituted and is undergoing right now, and it will give us better perspective of how these mechanical ventilator the practical approaches of mechanical ventilatory parameters and lung protective ventilation affecting the acute brain injury patients. So with this, we conclude our session on the brain vent study. I'd like to thank NCSI for the same. Thank you.
Thank you, ma'am. Thank you, NCSI.
Thank you. Thanks, Bhargavi.
For giving me this opportunity.